Year. Compliments of the season to you. Again, this is the upper GI session, and this week we're going to talk about an approach to subepithelial tumours. There's a few of them, they're pretty rare, but I'm sure we're going to find out the ABC of doing it and the practicalities of managing these patients. As you know, it's hosted by the Gastro Foundation in association with Project echo of the University of New Mexico. Sessions are always on a Wednesday, and please remember to interact with us and put any questions that you might have in the chat or at the end of the talk. If you can also raise your hand and speak to us, it's always good to put a face and a voice to the name. So Galya Chinnery, who's the Senior Consultant Associate Professor of Upper GI at Grooteskier, is going to talk to us on the topic that I've outlined about subepithelial gastric tumours. Over to you, Galya.
Thanks, Prof. Afternoon, everyone. Let me just screen share, one sec. Okay, won't you confirm, Prof, if that's visible, please?
Yes, it is.
Great. Thanks, everyone. Right. Today, I'm going to keep it very practical, and the idea is for us to have an approach to identifying subepithelial gastric tumors endoscopically, and not immediately reach for the CT booking form. So I've got one or two slides which I'd really like you to remember, or specifically there's an article which I'd like you to take note of for future reference. It's really one of my favorite approaches to SETs. But let's take it through step by step, and then we can, see how to go. So just as an introduction, I've got a patient that we saw, I think it's about almost 2 years now, 56-year-old gentleman, and his presenting complaint was postprandial vomiting with early satiety for the last 6 weeks. Not much loss of weight. BMI was 37. Previous meningioma excision, type 2 diabetic, and hypertensive. In addition, of relevance for us in this, he had iron deficiency anemia confirmed on bloods and was subsequently referred to us for a scope. I do hope this kind of presents, it's a little bit dark. It's the only photo I have of his original scope. But what I hope you can appreciate is that there in the background is the scope, and we just retroflexing in the distal stomach. And what we can see here is this large mass in the distal body antrum region. And perhaps if you can appreciate a little bit closely, there is an ulceration just on the aspect. Perhaps you can see that, I hope so. And the overlying mucosa for the rest of the mass is essentially normal. So if you're looking just at that, what would you think might be in your head as regards a differential? So for me, I mean, you're looking at a whole lot of different things, but this is quite a big thing, and there's a concerning umbilication or ulceration, whatever you want to call it. So I would put a few things in there. I don't know if anybody has any ideas, but for me, I would have thought a gastrointestinal stromal tumor would be top of my list. And there's a couple of other things that would be there too. This patient, due to the size, actually had a CT scan. I'm going to quickly show you that just for interest. So you can see us coming through into the abdomen, stomach, and there's the mass. Quite clearly, a very homogeneous distal gastric body antral mass. We go back up. You can take another look quickly. Now, for those of you that are quite familiar with CT abdomens and looking at these kind of tumors, you will appreciate that with that kind of picture is most likely to be a lipoma of the stomach. We'll talk a little bit about Hounsfield's units later, but at the moment that doesn't look like a GIST, it looks like a lipoma. So subepithelial tumors, I think first of all, get the terminology right. So that's what it's called. It should not be termed submucosal tumors because we need to include everything beneath the epithelium, the mucosa. So it includes the submucosal layer. So for academic reasons, I think that definition, that term should be quite clear in your head. Subepithelial tumors, SETs. Now, for the most part, they're incidental and fortunately asymptomatic. However, it is definitely something you're going to be coming across when you're doing a lot of scope lists. Approximately 2% of normal scopes, you'll find an incidental SET. Most can be diagnosed as to their origin endoscopically, and that's specifically the aim of today's talk. So when you next see one, there's a couple of things you really should be trying to observe carefully and making a note of in your report. Look at the size. You need to judge the size. We'll talk about how to do that. Shape, the color, the mobility, where specifically is it situated, and of course, what consistency can you appreciate endoscopically of it. Mucosa for the SETs generally overlying is normal, and of course we'll all be aware of that incident of the concern of ulceration or erosion, possibly indicating a malignancy. Now, this is the first slide I'd like you to remember. This is a beautiful article, in my opinion. It gives such a nice approach. It's in Gut and Liver from 2022, I think. Very nice approach, and I'm going to be referencing a lot of the approaches from this article by Kim. So, can the shape first of all help us determine the origin of a subepithelial tumor that you've come across? So for me, I like to simplify things. So macroscopically, if you've got a mass that sits on your gastric mucosa, like a setting sun, almost got a little bit of a belt pulling it in at the level of the mucosa, this thing is originating from a deeper layer. On the other side, if you've got something almost like a polyp, it's indicative that this is from a superficial layer. Yamada et al. From 1974 already classified this type 1 to type 4, and I think quite clearly that's kind of what I was trying to say. Type 1 and type 2, where you've got the sort of setting sun look, these are subepithelial tumors that are originating from the deeper submucosa or even the muscularis propria. So that would include GISTs, leiomyomas, or schwannomas. And then just an example to show you. So here we're going down towards the distal body antrum. And what you see there is a nice mass, which to me looks more like the setting sun kind of look, in that it's going to be something from the deeper layers. When we come back, you can also appreciate it's got a slight yellow tinge to it. Perhaps that doesn't really show nicely on the screens, but this was a lipoma. Now, if you're looking at the more rising sun look, type 3, type 4, these are obviously originating from more superficial layers, so either the deep mucosal or the superficial submucosal layer. And there you might be finding something like a vannix, an inflammatory fibroid polyp, or granular cell tumors, for example. So I think the shape of it, take note of the shape. It's not a waste of time. You can get a good idea of what layer this is potentially coming from. Just as an example, this is an inflammatory fibroid polyp, quite a large one. And the patient actually presented with intussusception. And you can see it here being sucked through into the pylorus, pulling it back, and quite a large tumor pulled out. And that came as a vannix, as I said. Does the position change your diagnosis? So we've looked at it macroscopically. So the next thing to look at, where in your stomach is this SET actually sitting? And I would suggest that you have this picture in your mind as well. It's quite useful. Most of us will appreciate that the vast majority of GISTs are fundal, and they often also sit around the cardia, but for the majority, they seem to sit very proximally. Why exactly that is, I can't quite answer you if I haven't found a good reason for that. The other thing that has a predilection for the proximal stomach are the granular cell tumors. Leiomyomas seem to hug the OG junction and are quite fond of the distal esophageal positioning, but often with a bit of overlap across into the OG junction cardia region. The other thing that you might find higher up as regards SETs are neuroendocrines and duplication cysts. Then gastric body, I've seen one gastritis cystica profunda. I really think that's unusual. I've got a picture I'll show you just now. And a schwannoma might be sitting there. And then as you go distally towards the distal gastric body and antrum, you're going to be finding the things that we see more commonly: ectopic pancreas, lipomas, again, an IFP, inflammatory fibroid polyp, and potentially a glomus tumor. So that's position. So have that in your head. So you can start differentiating where things are sitting. Then we try and look at the color. So this is from this article, and of course you'll appreciate it much nicer in real time when you're actually there and can, judge your color a little bit better by focusing your light and your positioning better. But for the most part, you can differentiate what is kind of the usual pinkish look. And then what you often see is the lipomas. They do shine through a beautiful pale kind of yellowish appearance compared to the rest of the mucosa. And then the more vascular things will look a little bit blue. Maybe you can see that. And then the translucent sort of, things that might be the fluid that you can see submucosally. I can't say I've seen that often. I'll show you just now. I've seen that once. Then the next thing to look at is obviously surface characteristics. You want to know, is the mucosa overlying your SET completely smooth? Is there potentially an umbilication? Perhaps you can see that there, or a tiny little opening, or what's most concerning, of course, to all of us is whether there's an ulceration on that surface of your SET. What we have here, I hope you can all immediately appreciate. This is not something you need to biopsy. This is a ectopic pancreas, and this is its kind of very classic positioning. You can get variations, of course, but if you're going towards the antrum, just before you get to the pylorus, on the greater curvature, if you see this kind of donut-shaped mass with an umbilication, that is a pancreatic remnant. You do not need to biopsy it, and you most definitely do not need to remove it. It's fairly common, completely incidental, and has no clinical ramifications in about 1 in 1,000 people. So it's quite fairly common. So let's talk a little bit about ulceration. Another view of a mid-body kind of SET, and you see a rather nasty looking ulceration. If you retroflex, it is probably actually proximal body, a little bit higher than initially thought when you go down. And that, I will think we will all agree, is most likely to be a gastrointestinal stromal tumor. So the concerns with ulcerations is, of course, this is potentially a malignancy. Common tumors, SETs that do ulcerate are neuroendocrines, as in the first picture, lymphoid tissue on occasion, and then variations of whatever funny carcinomas, and then the most common that we're all appreciative of having seen many times before, I'm sure, gastrointestinal stromal tumors. The next thing you look for is movability. But first of all, what is it? The movability of an SET, you can ascertain basically by giving it a poke with an endoscopy biopsy forceps. If you, the best way to describe it to me is if you push your biopsy forceps, keep your forceps closed, and you push it towards the little mass. If it sort of runs away from you like a mouse under a carpet, that's termed the rolling sign, and it's clearly that SET is not attached to the overlying mucosa. Similarly, just to be aware of the terminology, people refer to a pillow sign, where you place your endoscopic biopsy on top of the lesion and push down. And similarly, as you would expect a head indentation on a pillow. That's a soft movable SET. Just for interest, if you are struggling and you're really desperate to biopsy a mobile subepithelial tumor, a trick that we've tried using, it's a bit fiddly, I'm not going to lie, but what you can do is you can put, what's that, the string that you clean your teeth with. I've forgotten the name now. Anyway, I hope you know what I mean.
Floss.
Floss.
Floss, exactly. There we go. We've tied a little bit of floss to a clip, and then you clip your hemostatic clip onto the mucosa such that you can actually pull the floss through your scope and kind of keep that mass from moving away from you as you progress with your biopsy or your needle. Specifically, when we use the FNA needles, we don't always use an EUS, I confess, but it's nice to pull that movable little mass towards you, and then you can give it a nice biopsy without it running away from you. So that's just a trick. The other thing to do, if you've got something bigger and you're quite happy and that there's nothing vascular underneath, perhaps even if you have the availability of an EUS in your system, that would obviously be ideal, but I do appreciate the majority of us don't have that. You can do an incisional approach where you can use, we always use just the simple needle knife that the HPB colleagues use to do their sphincterotomies. And we just cut open the overlying mucosa such that the underlying tissue of the SET is exposed. And then you can do a nice targeted biopsy of that specific tissue. Now, the other option is to do stacked biopsies. I think it's a little bit messy sometimes in that specifically if the mucosa is mobile, it's easier to cut. It sounds scary, but just cut it a little bit. You just need 1 centimeter, that's it. Then your underlying tissue is exposed. The stacked biopsies, to me, yeah, they don't give such good results unless you are biopsying in an area of an ulceration. That clearly gives you a good result. But yeah, stacked biopsies to me is second choice. What is tenting? That is something else that you can put down on your description of your tumor that you found. It basically means, again, movability in that you take your biopsy forceps through the scope, grab the overlying mucosa of your SET, and if it lifts up beautifully, again, it confirms that this is not something that's infiltrating through into your mucosa. So it's just another thing confirming movability. How can I measure size? Now that sounds so simple. Everything is magnified, and I think it takes a lot of scopes before you can judge fairly accurately, and you're not always that accurate, but before you can judge fairly well whether something is small, large, 5 millimeters, 10, whatever. So use something that you know the size of, and the commonest thing, easiest thing is to appreciate just on retroflexion how big is whatever tumor you're looking at in comparison to your scope diameter. Now I do appreciate, of course, that the distance from the tumor makes a difference, but you can quite fairly and confidently say that that SET is probably sitting at about, I don't know, 10 to 12 millimeters. Similarly, look at your biopsy forceps that you use in your unit. In our unit, we've measured them. If you open them up nicely, they're just under 6 millimeters in diameter. So if you open up your forceps, you can have a bit of an idea of how big something is. So for example, here, if that's the same forceps as us, that's already just over 5 millimeters. So that's probably sitting at about 12 millimeters as well. Some of the guide wires you use in your unit may be, for lack of a better word, striated, and those separations are usually centimeters, but just check. There is a Savary-Gillard wire that's also got measurements on them. That's quite nice. We don't have that, but I have seen people who have that. So yeah, for our part, we usually sit with a biopsy forceps and the scope. Of course, if you have an EUS, fantastic. That's the best and most accurate. But this is just for a first impression when you're looking at the size. What about considering insufflation effect? Now, I think, especially when you're starting, the tendency is to take a little bit longer, and your insufflation of that stomach is quite often to the point that it's really uncomfortable, specifically in our setup where a lot of the scopes are still done only under pharyngeal anesthetic. So I do think appreciate the insufflation effect. What is it? Well, basically, the bigger you blow up your stomach, the more external organs will start compressing into the lumen of what you see on your screen. So specifically, bear that in mind. Different things, obviously, there are malignant processes in the liver, whatever, that can press in. But I think for the majority, I want you to remember that normal things can give you rather dramatic extraluminal gastric compression effects. So this, for example, is a very big antral SET until you let out the air and you realize this is just a very large gallbladder due to the patient being starved. So be aware of that. If you suck out your air and it suddenly disappears, well, then you know it's extraluminal and it was not an SET. Similarly, on the retroflexed view, you may well see the left lobe of the liver, sometimes the kidney, and if you have a large spleen. So beware of that. And sometimes on the posterior aspect, I've not seen it this clear, must be very honest, but they do say you can see a splenic vasculature on occasion. Then obviously, please don't put your needle in there, rather get someone with an EUS to confirm. But this is basically the list of the most common normal intraluminal impressions that you get with a lot of insufflation. Okay, so let's go back to our patient that we started off with. We had suggested on the CT scan that this may well be a lipoma, looking at the homogeneity of it. If the Hounsfields were measured, it's classic for a lipoma to be between -120 and -70. So that's quite classic for a lipoma. The other thing you can do is, if you're just looking quickly, you can look at the fatty tissues in the surrounding subcutaneous tissues of the patient. If it's a similar density, you can be fairly confident that this is a gastric distal lipoma. This is a beautiful but busy, but don't be put off by it, table from the same article I suggested you all take a look at. And it basically mentions all the common SETs that you might find in the stomach, and then puts their location, shape, color, surface, movability, and consistency into a single table. So if we go back to that original lesion I showed you, mass I showed you, if you look at the table, have this somewhere in your endoscopy room for what it's worth. If you then circle where it's sitting, so okay, fine, we decided this was sitting distal body antrum, quite a large one, so those are the common things that are sitting in that place. Then we decided the lesion had an erosion or an ulceration. So those are the surface the characteristics of SETs with surface ulceration. So usually a GIST, a lymphoma, an IFP, SET like carcinoma, or metastases of some origin. Then if we look at the color, oh, I don't know what that was. Oh, what's happening there? Not sure what that is. But the color is yellow. If it were yellowish, then you might consider a granular cell tumor or a lipoma. Similarly, we had decided it was fairly movable, so we circle the movable ones there. And then finally, if you look a bit further, the consistency was quite soft. We gave it a poke. And then if you put everything together, that is the SET with most circled characteristics. So I think from this table, you can get a fairly good idea of what you are actually sitting with potentially. Granted that the ulceration erosion on the side was a bit unusual, but you've still got 4 out of 6 characteristics fitting in with a lipoma. Putting it a little bit differently, this is also, I'm sorry, I don't know what those stripes are. Anyway, this is also from Kim's article from 2022, looking at it a little bit differently. Again, putting it into a more of an algorithm kind of setup. Look at the location. You look at the color. If it's yellowish, translucent, obviously it's a potentially a vascular thing or lipoma or a cyst kind of thing. Look at the cushioning effect. Look at whether there's an erosion or not. If there is, be very much aware that there is a potential chance for malignancy, go for a biopsy. If, however, the mucosa is nice and loose, rolling, tenting, you don't need to rush straight forward for a biopsy. Then look at the size, measure the size. If it's less than a centimeter, it's honestly quite safe to observe this thing for growth over the next couple of months. You don't need to spring forwards and go find an urgent CT. If you have the availability of an EUS, fantastic, please do so. And that is, of course, suggested if there is something over a centimeter in size. And that obviously can also help you biopsy, targeted biopsies, much easier with an EUS. Just a brief word. I think it's quite easy to, especially with the big lipomas, to be confused between a lipoma and a GIST if you're not careful or if you haven't seen enough. For the CT scans, well, clearly you can see the lipoma. This is what I was trying to say just now. The consistency, the appearance of that gastric lipoma is similar to the visceral fat or even the subcutaneous fat. It just looks similar, but then you can, of course, get a nice confirmation measurement of your Hounsfield's units. Whereas a GIST is typically heterogeneous and very solid by comparison. So if you put the CT plus your endoscopic findings together, you can pretty confidently differentiate between the two without even having a biopsy. Let's go back to our patient that we started off with. This antral lipoma, what would your plans be? In this case, remember, I'll just take you back. He was late 50s and he came to us with complaints of vomiting and essentially gastric outlet type of picture. So clearly, although this was confirmed on that biopsy of the ulceration to be a lipoma, this was not something we wanted to leave behind. You'll also remember he started his blood work with an iron deficiency anemia and clearly was bleeding from that erosion. Was it something to do with pressure? I don't know, but there was that concern too. Now, if you have a small lipoma, it is quite a nice tumor to approach endoscopically. You mark out your, this is not my picture, I don't have quite a nice one like this, but you mark out your diameter that you are approaching and then infiltrate as per usual with your submucosal lift, whatever agent you use. I personally like to use a combination of saline and methylene blue. It's super cheap, easily available, and you get that nice, beautiful differentiation of the layers. It helps you to identify specifically, of course, the muscle, which you're avoiding as far as is possible. The lipoma itself is so beautifully dissected out. It's usually probably one of the easiest things to take out as regards the SETs. Whether you need to close the overlying mucosa afterwards, That's a bit contentious. I think if it's very small and you've clearly got no bleeding, I tend to leave them alone. However, for the patient in question, I think you'll agree, this was a bit large to tackle endoscopically. Perhaps somebody else would have. We opted to actually take him to theatre. We gave him a partial gastrectomy, which you can definitely argue against. I think you could have opened a gastrotomy and potentially shelled this tumor out, this lipoma out. I think that would have been very fair. And in retrospect, that's probably what we should have done. However, life's not like that, and it's easy looking back. We then complicated as regards our patient with persistent post-operative vomiting. So what would your plan have been? So for us, wherever there's an anastomosis and you're getting delayed emptying, the first concern, of course, would always be that there's an undiagnosed collection, creating some havoc with the motility in some regard or compressing. So the first thing we did was obviously do a CT scan. And you'll appreciate the anatomy now looks a little bit different in that we have now hooked up our B1 gastrectomy anastomosis, so duodenum to the rest of the stomach. We've got a tube in there. But you can clearly see, I hope, it projects that there isn't really an inflammatory component specifically that we can blame for causing this gastric outlet obstruction. So to this day, I'm not quite sure why he had a GU, why he developed this stricture, but definitely he did. And our plans were subsequently to wait it out. So we put down a nasogenic tube, fed him up a bit, and then tried to balloon dilate that anastomosis. Did not work. And we eventually resorted to putting down a temporary duodenal stent, which did the job nicely and was removed later without an issue, and he's pretty fine now. All that in a nutshell. Let's look at this tumor. So this is completely different, and I just want you to have an idea. So what we're looking at here is mid-gastric body, and there's an interception. Something has been completely intercepted through the pylorus into the duodenum. And this patient came with severe abdominal pain postprandially with significant vomiting of some duration. We could get through. And when you come back, you see that there's definitely some sort of lesion there with an ulceration clearly visible. And if you wait long enough, it pops back out. It was quite an impressive thing to see. And there you clearly see a subepithelial tumor with 2 areas of ulceration. Excuse me. So looking just at that, you can judge it's quite a large lesion. The overlying mucosa, for the most part, is normal. When you retroflex and it's been spat out by the pylorus, it's actually quite high up, so proximal stomach. And there is, of course, as we saw, 2 areas of ulceration. It also looks like the rising sun kind of image in that it looks more potentially superficial, but looking at the scope, you can appreciate this is quite a large mass. So back to that beautiful table of Kim. If you were to circle all the positive traits, so first of all, where it's sitting, so let's say it's fundus and upper body, so that fits in there. So granular cell, no, clearly not. GIST, maybe. Neuroendocrine, unlikely. Duplication cyst, probably not with that ulceration. Schwannoma, maybe. Gastritis cystica profunda, no. Lymphoma doesn't look like it either. Then the shape, I said the rising sun rather, so a Yamada type 2, 3 or 4. And there's not much there, so maybe an inflammatory fibroid polyp, so looking more superficial. Then the color looks normal, so that kind of fits in with the vast majority of everything. We do, however, have an erosion. So, okay, might be an inflammatory fibroid, might be some kind of malignancy, and of course, the NETs and the GISTs fit in there. Movability, yes, it's mobile in that it got intercepted through the pylorus, but once you've got an ulceration like that, you can really assume that the mucosa isn't that mobile over that growth. So there's a lot of SETs that are not movable, and then the consistency was definitely quite hard. So looking at all of those, which of those characteristics are falling into the highest category, leaves us with a gastrointestinal stromal tumor and an inflammatory fibroid polyp. This clearly is the one to go for. And although you had that kind of setting, rising sun picture, I think it was just such a very heavy tumor on such a small stalk that it was able to prolapse like that. And we actually did a wedge resection and confirmed that this was indeed a gastrointestinal stromal tumor. So this table's not the be all and end all. It just gives you a narrowed differential diagnosis to the SETs. I really do think it's quite useful to have this article somewhere in your memory. It's very nice. My final quick video I'd like to show you. This is a lady of 40-something with dyspepsia and vomiting. And when you go down into the stomach, you'll see sort of mid-gastric body, there's that polypoid, probably about 6 centimeters, with some erosion on the right aspect. Looks like it's narrowing a little bit. If you go through there, you come to a fairly normal antrum. But if you took the time to look at that carefully, you'll see that the mucosa is infiltrated all around that. And this is indeed not a subepithelial. This was in fact a adenocarcinoma. So don't be fooled. Look at the surrounding mucosa of your so-called SET as well, because it can definitely exclude certain differentials quite clearly. So not everything is an SET. And occasionally we see a rather polypoid adenocarcinoma of the stomach. Prof, that's my practical approach to trying to identify SETs endoscopically. I don't know if there are any questions.
Thanks very much, Galya. There is one about the pillow sign as to how useful it is from Dr. Asmari.
I think look, none of these signs are absolute. I think you must remember to put everything together and contextualize all your findings and then make a plan. So to me, the pillow sign is just an indication that this is soft. And things that are soft are generally benign. And if I've got something small and soft, I'm quite happy to leave it alone and just observe it conservatively. So useful in that it kind of reassures me. But yeah, it's usually a lipoma or something vascular or cystic. It's just a reassuring thing. If I see a pillow sign, I'm quite happy.
I must admit there's a couple of things regarding ulceration. And in respect to, certainly when you see most of the lipomas that I've seen, and you also see them quite commonly at colonoscopy, they're usually quite easy to identify because of the yellowness, and sometimes they have a little vascular pattern on the top of them. But I've rarely seen them ulcerate, to be honest. And obviously, that's usually a sign of fast growth, that it sort of necroses the mucosa that's over them, and that makes them worrisome. So again, like your lesion there, but it was a lipoma, it wasn't a liposarcoma.
No, that's why I put it in, because it kind of threw us really a ball in that to me was a guess.
Yes.
Until we saw the CT and then we were like, okay, that's a bit unusual. And then we actually got the biopsies back afterwards, which was lipoma. But yeah, our reason for resecting it was that we thought there was something sneaky underlying this ulceration. But once we got it back, completely benign, and bearing in mind the considerable complications the patient had after, you could, had you known all of that, you might have shelled it out.
Yes.
Yeah. that one, no, is definitely not what you normally would see. I agree with you. They're beautiful, small, soft, very yellow, even in the stomach. I think the colon ones are more yellow because the mucosa is thinner. But they usually, yeah, very easily identifiable.
Because most of the time when we see them, we leave them alone. They're like the pancreatic rests. They
Yes.
really, and especially in the colon, it's very unlikely unless they're causing this intussusception or their physical size is doing it. One of the other things about the GISTs is that sometimes they have a big exophytic proportion, that what you see is like a dumbbell, and the biggest bit of the dumbbell is actually outside the stomach. So what makes you do a CT? Is it just size, or that you can't really characterize it?
I'm quite cautious of GISTs, having been caught out once or twice. And once I've got a GIST in my head, Prof, I will always CT them. You're absolutely correct. It's not sometimes just a dumbbell, it's sometimes the tip of an iceberg.
Yeah.
So yeah, we always CT our GISTs, and I think for the most part you will be wanting to take them out anyway. And positioning on scope, yeah, it's funny. Sometimes you think you're absolutely sure this is anterior, and then you do the CT and you're like, oh goodness, heck, that's posterior. And then approaching a wedge resection laparoscopically kind of ups it a little bit. So I think a CT for me, for a GIST, always.
Yes. Yeah, again, I think if they're sitting on the lesser curve, they're also not quite so easy to tackle. Yeah, because there's a few big blood vessels there, I seem to remember. Yeah. So yeah, these it's very interesting, but obviously we remember the ones that intussuscept, and they're fantastic when you see them. And yeah, do you usually think most of them require surgery in terms of open surgery, or do you think you can deal with them endoscopically?
No, I think most of the things that intussuscept are small enough to pass through for the majority, to pass through the pylorus. I don't know if you recall that picture of the vannix, or the inflammatory fibroid that we took
Yeah.
out. And there, I'll be honest, it's a little bit scary when you take out those big ones. You have to get it out the esophagus. And I think their sedation, or adequate, proper sedation, is essential, because that's the time the patient's going to gag. And you really don't want someone rupturing their esophagus because you're trying to get a jolly benign tumor out. So that one, I'll be honest, I was quite surprised how big it was, and we had underestimated that. And perhaps that should have been done under a general anesthetic where it's quite safe to pull
Yes.
slow. Where conscious sedation, I think that's
Yeah.
a boer of waiting to happen potentially. So
Yes,
yeah.
never nice. There's a question here also from Asmari about these extrinsic things. He's talking about a splenic artery aneurysm. And I certainly know that we explored a gentleman who we did a CT on, who had a non-ulcerating, we thought, big thing on the lesser surface. And it turned out it was a big hepatic adenoma. We got quite a shock when we opened him up. So the radiologist had misinterpreted it. And again, sort of, so it's really, they can be quite confusing when they really bulge in a lot. And obviously, if you see the aneurysm, obviously there's a few things that are pulsating there, but usually if you see something that's pulsating in the stomach, it's not a great idea. But have you I mean, we all come across these things, but what's your worst experience with something that you think is something else and is actually extrinsic?
I've stuck a needle into an abdominal aortic aneurysm, and that was quite spectacular. I shall remember for a while. Yeah.
Yes.
Just while we're talking about spectacular things that bleed, I was mentioning further earlier that the stack biopsies are best done in an area of ulceration. Now, I think a word of caution, if I may. Yes, you will get better representation of the underlying tissue rather than going somewhere else. But if it's a GIST, that's where it's bled from. So if you're going to nibble away at tissue in that area, you must be able to sort it out. So either you take that patient to theatre afterwards, or you're able to slam on an Ovesco clip or something. But if you're not able to manage the bleeding from there, don't biopsy it there. So yeah, we've had some nice bleeds there.
And how many, one last question from me. How many of them do you actually send for EUS for a diagnosis? Because lipoma is notoriously difficult to diagnose on EUS in terms of getting any sample. But what about, how often would you say you refer them for EUS if you're not doing it?
I think, so I don't do EUSs myself, which means I have to find somebody else to do it, and that service is already quite overrun. So I would think it is something we utilize very seldomly. When I really do wish I had an EUS is when I've struggled repeatedly to get a biopsy of something I'm expecting to be a guest. And there we often kind of bite the bullet, have a CT scan, make sure there's no obvious vessels in that area, and then we take the EUS needles and we stick it through a normal G-scope. Again, yeah, with some caution, perhaps not something everyone should just do as a routine. If you have EUS, of course, that's the way to go.
Yes. Again, there's a question here from Asmari from Ethiopia. But yes, Asmari, this talk is available on the Gastro Foundation website, so you can access it there, and you can send your other gastroenterology colleagues to that site, and you can certainly let them know that they're more than welcome to join the G-Echo. Does anybody else want to put their hand up and ask any questions? I think you've got a good working diagnosis, especially for the things that you will see more commonly. Some of these things are extremely rare, and even for experienced endoscopies, they see them once or twice in their endoscopic career.
We've got Masha's hand up, Sandy.
Oh yeah, Mashiko, please unmask yourself and speak to us.
Thanks, Prof. Galya, excellent as always. I was just curious, given that we are a referral center, would you say the prevalence of GIST that we diagnose is higher than reported? I mean, you have a large series, so I'm wondering if you have an idea of how commonly we see these in the stomach, whether they're complicated or not, bleeding or not.
They often, Mashiko, they often present with an upper GI bleed as the first presentation. And yeah, I would, it's not infrequent, but we still, the numbers in South Africa are not clear. Yes, there's some oncology reviews, but again, overall, I don't think we really know our incidence, to be honest. I know we're a referral center, but I still think, I mean, we see them often enough to recognize them immediately most of the time, but it's not something that comes through the door every week. So tricky one to answer, I'm afraid.
Yeah, that is my sense, that we do see them often enough, you know, which I gave me the sense that maybe we are seeing a lot, but I mean, like you say, it's all relative, and if you don't have the background population and so forth, it's hard to say. But yeah, thanks. That was very, very clear. Learned a lot.
Interestingly enough, Colin Rush and I think recently Edwin on this WhatsApp chat group have posted two GISTs in the well, one in the upper foregut and the other was in the fourth part of the duodenum. So again, it's important to remember that even though GISTs, the commonest site is the stomach, they do go down the GI tract and go almost everywhere. So they're a very interesting group of patients. I wrote up a series of leiomyomas way before they did staining back in my Durban days. And again, once they started to have staining for leiomyomas, about 90% of what they were diagnosing as leiomyomas were actually GISTs. So I think leiomyomas are also quite rare now that most of these lesions will be subjected to the staining. So
yeah, I can't remember the last time we had a leiomyoma diagnosed. They're all coming. Oh, we've had one. That was esophagus.
yeah, I think they're pretty much rare as hens, to be honest. I think you're more likely to get them in the esophagus, and then they can be bloody huge before they manifest. Anyway, I'd just like to thank everybody for participating. with the discussion, even though I hogged it a bit, and for Galya for providing all the answers. I think you've got a really good working algorithm here, and obviously that article should be in your in tray for that. So it just remains for me to thank everyone, to thank the girls who organised this whole thing, iEcho India, and just to remind you that there is one next week. I'm not sure exactly who it is. Maybe Cheryl can tell us, but please keep attending and tell your other colleagues that if you feel this is a worthwhile experience to join us on a Wednesday. Look forward to seeing you again in the near future. Thank you, everyone.